So you're prepping for the ATI Pediatric Nursing Exam, and wow, there's a lot to cover, right? Well, in this explainer, we're going to cut right through all that noise. We'll focus on the absolute must-know concepts that show up all the time, breaking them down so they actually stick.
Okay, here's our game plan. We'll kick things off with the big picture challenge of peds care. Then we'll dive deep into three critical areas: medication safety, pain management, and the fear that comes with hospitalization. And finally, we'll talk about the complexities of end-of-life care.
Okay, so everything we're about to talk about, it all comes down to one core non-negotiable principle. Children are not just little adults. It's as simple as that. From their metabolism to their emotional needs, every single system is still under construction. For your exam, and more importantly, for your practice, every decision has to be seen through that lens of what developmental stage the child is in.
And this quote right here, straight from your ATI book, really just nails why pediatric nursing is so intense. Because a child's organs are still maturing, the way their bodies handle medication can be really unpredictable. This isn't just some random biological fact. It's basically a big warning sign. It's exactly why our first topic, medication safety, is a total zero-error zone.
All right, so when it comes to giving meds, you're basically juggling two super important goals. First, the math has to be absolutely perfect for safety, no question. And second, the way you give it has to be as gentle and trauma-free as possible. Let's look at how to get both of those right.
Okay, this is a huge point for your exam, so listen up. Pediatric doses are never, ever standard. They're always custom calculated based on things like age, weight in kilograms, always kilograms, or sometimes body surface area. And listen, the two biggest safety nets you have, they're simple but absolutely critical. Get a second nurse to double-check your math on high-risk drugs and use at least 2 patient identifiers every single time.
All right, here is a classic ATI-style question, the kind that seems really simple but can totally trip you up if you're not careful. You've got an infant and a 4-year-old. They both need eardrops. How is your technique different?
And here's the answer. For a little one, a child under 3, you're going to gently pull the pinna down and back. But for any kid over 3, you pull it up and back. This one simple change accounts for how the ear canal straightens out as they grow. It's one of those tiny details that has a massive impact on whether the treatment actually works.
And this all leads us to a concept you are going to see everywhere on your exam: atraumatic care. This isn't just about being nice, it's a clinical strategy. Think about it. Giving a baby a sucrose pacifier, using what's called therapeutic hugging, or putting some numbing cream on an hour before a shot. These aren't just nice things to do. They are actual clinical interventions that reduce pain and anxiety.
So, just like we have special techniques to make procedures less painful, we also need special tools to figure out how much pain a child is in, especially when they can't just tell us. Honestly, decoding pain in kids is one of the biggest challenges, and it really does require you to be part detective.
Okay, pay attention here because this slide is pure gold for your exam. The absolute key is matching the right tool to the child's developmental age. You can't ask a 2-year-old to rate their pain from 1 to 10, right? Of course not. For them, you'd use an observational scale like FLAC. Knowing which tool to grab for which age is a non-negotiable, fundamental skill.
So let's dive into that FLAC scale, which is going to be your go-to for infants and nonverbal kids. It's an acronym for the 5 things you're literally just watching for: their face, their legs, their activity level, their cry, and how easily they can be consoled. It takes what you're seeing and turns it into a real, objective score that helps guide what you do next.
So once you've got that pain score, what do? Well, your treatment plan should follow this really simple 2-step ladder from the WHO. Step 1, for mild pain in kids over 3 months, you start with a non-opioid, like an NSAID. Step 2, if that's not cutting it, or if the pain is moderate to severe right from the get-go, you escalate to a strong opioid like morphine.
Pain isn't just physical. The psychological pain of being in a hospital can be just as devastating for a child, if not more so. They're scared, they've lost all control, and they're separated from everything that makes them feel safe. Our job as nurses is to manage that fear just as aggressively as we manage any physical symptom.
Okay, for infants and toddlers, the absolute biggest stressor is separation anxiety, and you have to know the 3 stages for your exam. It all starts with protest. This is the obvious one, right? The child is crying loudly, clinging to their parents for dear life, and actively pushing away strangers, which, by the way, is us.
Now, if that protest stage isn't resolved, the child can slip into stage 2, despair. And this is the tricky one because the loud crying stops.
The child just gets quiet, withdrawn. You might even see them regress, like a potty-trained toddler who starts having accidents again. It's so important to recognize this isn't the child getting better, it's a sign they're losing hope. And then we have the final stage, detachment, which is honestly the easiest one to get wrong. The child might seem happy, they start playing and interacting with the nurses, it looks like they finally adjusted. But really, it's a defense mechanism. The big giveaway is that when the parents come back, the child might just ignore them. They've had to disconnect emotionally to cope.
So, how do we stop a child from ever reaching despair or detachment? Our single, most powerful tool? It's therapeutic play. This is not just about keeping them busy or distracted. It is a legitimate, clinical intervention. You can use a doll to show a preschooler what's about to happen in a procedure, or get a school-aged kid playing a game with another patient. Play is how kids make sense of their world, and it's how we give them back a little bit of control.
All right, we're shifting gears now to what is, without a doubt, the most difficult and profound part of pediatric nursing, end-of-life care. This is where your clinical skills, your communication, and your compassion are all put to the ultimate test. The guiding philosophy here is palliative care. And for your exam, please understand, palliative care is not about giving up. Not at all. It's an active, compassionate approach where the goal shifts from cure to comfort, to maximizing the quality of life for whatever time is left. The focus is on symptom management and supporting the entire family.
And this timeline right here perfectly illustrates why your communication has to be tailored so carefully. A little preschooler might think death isn't permanent, that it's reversible. Because of their magical thinking, they might even think they caused the illness with a bad thought. But an adolescent, they get that it's final, and they might express that as anger or frustration about a future they're being robbed of. You have to meet them where they are.
As the nurse, it's so important to recognize the physical signs that death is near, mainly so you can help prepare the family. This includes things like the skin feeling cool but the child feeling hot, changes in breathing patterns like Cheyne-Stokes, and a gradual loss of their senses. But here is a major takeaway for the exam and for your career. Always assume the child can hear you. Hearing is believed to be the very last sense to go.
So when it comes right down to it, in pediatric end-of-life care, your patient is not just the child. It's the whole family. Your job, your responsibility, is to support them through the grief before death, to be a calm presence during the event, and to provide them with resources for the painful bereavement that follows. And that brings us to a final, really important question, one that goes way beyond any test. How do you give this level of care, this piece of yourself, over and over without completely burning out? Mastering the clinical stuff, that's step one. But the real journey, and honestly the greatest reward of this work, is figuring out how to take care of yourself so you can keep taking care of them.